Oh, thank you very much, Professor Healy, for that whistle-stop tour of 30 years worth of research. I'd like to thank all three of my fellow panelists, and I'd invite you to please turn on your camera. So this is time for questions to be answered. Currently, there are no questions in our Q&A box, and I'll encourage our audience to please use that. But as I was listening to those very excellent talks, I had a few thoughts. Let's start with Dr. Misra. Dr. Misra, I think you gave us a teaser, really. You said, is it worth it? Precision medicine and type 2 diabetes, is it worth it? We're getting increasingly efficacious agents in the GLP-1 category with other things on the horizon. So really, is it worth it?
Thanks, Chima. I mean, as with my clinical and research bias, of course, I think it's worth it because having access to fantastic agents like Ben was describing is, of course, wonderful. But as I showed with the case vignettes, those sorts of treatments, whether they're treatments that reduce weight or some other treatment, they're not appropriate for everyone. One size clearly does not fit all with type 2 diabetes. So we really need to identify multiple approaches, and we need good ways to stratify people. With my teaser statement, I think really what I'm getting at is this issue that concerns me greatly, which is that the 4 out of 5 people living with type 2 diabetes globally are in low and middle income countries who don't have a secure medication pipeline, let alone access to fancy stratification tools. And if anyone's interested in that, we wrote a piece about that in Lancet D&E recently. So I think whatever we do in the precision medicine space needs to deliver improvements with equity across all resource settings. And really, that's what I was trying to say, really, with that slightly flippant remark, because to those people living in resource restricted areas, there are probably greater priorities. But the corollary to that is that those individuals are also the greatest at risk of clinical errors. And so if we think of precision medicine as an approach that reduces errors, they also have a lot to gain.
Okay, thank you so much for enlightening us. Now, if I just go over to Dr. Jones. So you highlighted an example of how biased agonism could perhaps increase efficacy or help us choose more efficacious agents. But I guess with my clinician hat on, what about side effects? Could biased agonism have a role to play there?
Yeah, good question. So it's something which has often been discussed in the sort of biased agonism space. The idea that if you have more than one intracellular signaling pathway, maybe one is responsible for the beneficial effects and the other is responsible for the side effects. There is some evidence for that in other receptor systems, for example, opioid receptors, although I think that's a little controversial. For the GLP-1 receptor, I'm not so convinced that that's the case. Having said that, there is a caveat, which is that many of the biased agonists that we see, and in fact, there's a comment, I think, in the Q&A alluding to this, many of these are actually partial agonists. And there is a theoretical mechanism by which a partial agonist could show preferential signaling in certain tissues, for example, anorectic or emetic, so nausea-producing areas of the brain, and selectively reduced signaling in those kind of areas of the brain. So that could be therapeutically valuable as well, but not through the sort of mechanism which you might instantly think of if you start hearing about biased signaling.
Okay, thank you so much for that. And then I will take, this one is for you, Professor Morahili. So in the chat, someone has asked, if we can clarify how weight loss might be helpful in the management of metabolic disease. But I think I'll just want to extend that. Given what you presented about the difference in genetic susceptibility, especially where we store our fat and fat storage capabilities, how would we utilize that information when we're counseling, or advocating weight loss as part of the management strategy for obesity and/or type 2 diabetes?
So I saw that question in the Q&A, and it's an interesting one. I mean, there's no doubt that if you manage to lose weight, significant amounts of weight, you do take that lipid out of the non-professional tissues, you take it out of liver fat, and you do improve insulin sensitivity, and you can, for a period of time, even reverse hyperglycemia. And we know from the wonderful work of Mike Lean and Roy Taylor and the enthusiasts they are for this approach, there's been a feeling that maybe we could actually even get remission in type 2 diabetes. Now, the real world data on that, and there's been recent work from Hong Kong, etc., suggests that maybe that's a little optimistic that we can get that for a long time, and that yes, it's always beneficial. But the idea that the majority of people with type 2 diabetes, if they lost weight and kept it off, would be able to get on without medication, without any other something, is probably a little over optimistic in the real world. You got to remember that for many of these studies done by Roy and Mike, you know, there's a subset of people where it was a subset of people who chose to, very small subset, who chose to go to these protocols. It's highly selective, and so. I mean, the answer is yes, it's fantastic if you get that response, and some people can get a persistent response, but not all do. I mean, clearly, one of the paradoxes of type 2 diabetes, or paradoxes of diabetes research, is insulin was the first hormone ever to be measured, and we almost never measure it in clinical practice. And it's kind of bizarre, but there we are. We like being a thyroidologist and not measuring TSH, but yet we do that all the time because insulin is quite hard to measure. It's a bit of a mess. It has to be frozen. It has to be. So it's pretty strange that we try and practice this sort of endocrinology without measuring the key hormone. And you know what would be really nice is to be able to see if even short-term dietary takes someone, see what happens to their insulin resistance within a very short period of time of diet. And if they get a very good response, that could predict that they were going to do really well. But we don't do that sort of thing in clinical practice, sadly. If someone, I mean, Shivana showed a case, which was very likely to be a lean woman with quite substantial insulinopenia, they are much less likely to do well on caloric restriction because you're dealing with a primary but partial pancreatic beta cell defect, and that's very unlikely to do very well with and as one of the things that happens is as diabetes starts going into primary care, and sometimes often not just to the doctor but to a practice nurse, and sometimes even a less than qualified person, they just follow protocols, and unless people understand the heterogeneity of diabetes, then some pretty awful stuff can go on, and you know, people can be miserable for years being on inappropriate bits of an algorithm, and that's what we kind of, I think Shivana and I and Ben would want people to get a bit more thought being put into their personal therapy. You're muted.
Thank you so much. Classic error there. Thank you so much to Dr. Shivani Misra, Dr. Ben Jones, Professor Sir Stephen O'Reilly. Thank you so much to the Association of Physicians for hosting this webinar. And thank you so much to everybody who joined. I hope we've all learned a thing or two. I definitely have. And I hope that will help us to inform our research and our clinical practice as well. Thank you, everyone.